So we have Dr. Ranjani as well on the call. We have Mr. Krishna Reddy on the call as well. He has been the architect of this particular technology. We will try to answer all kinds of clinical as well as technical questions you might have if you're intrigued enough by this technology. So always feel free to put the questions on the chat box or just raise a hand on the options in Google Meet, and we'll open it up for questions after the first 15 or 20 odd minutes. So, starting with the problem that we are trying to address, it's cervical cancer, and this is something which kills almost one woman every 7 minutes in India and every 2 minutes across the world. If I'm looking at the entire world, the problem is that not enough screening is happening across India, South Asia, and parts of Africa. So most of the developing world has not been covered with cervical cancer screening process. There are multiple reasons associated. One of them being cost, the other being accessibility of the healthcare. So what we have been trying to build up is a low cost solution so that it becomes easy and much more reasonably priced for the government and everyone else to kind of get this the screening process in practice across India, make it accessible for everyone. We have been able to create a technology end to end, and this has grown up over the last year and a half or so as we have built it up piece by piece. So we started with something, and then we can talk about the journey as well as we go through it. But overall, right now we have a very good service in place, an end-to-end model where we are able to do starting from the collection, we have value engineered the entire kit, the processing, and finally the diagnostics and the reporting via an AI model. Coming to the next slide. So overall, WHO and the Indian Public Health Services, they have a very steep target of reaching around 70% screening by the year 2030. That's a very steep ask. And currently, considering we only have one like less than 1% of the population covered by uh, cancer screening, and that too by uh, not very highly sensitive technologies, it's going to be a very uphill task as we move ahead. So, the government of India, and if you have seen our Prime Minister Modi talking to Bill Gates about this particular problem and the kind of investments that India is planning to put both in vaccinations as well as the screening programs, that would be like that's going to be a very big game changer over the next 6 to 8 years as we battle cervical cancer as a very big problem in India. Our experience in the field indicates that over 5 to 7% incident rates we are observing for HPV in rural areas. We have done over 1,000 plus screenings in the rural areas of Telangana and close to Hyderabad. And in each of these screening programs, we are seeing lots and lots, like we are seeing almost 5 to 7% incident rates coming up, and that's kind of shocking. The other thing that we are also observing is the different strains of HPV. So even though the vaccine that the government of India is advocating, it only covers 4 strains of the virus out of say 32 odd that are currently in existence. So we do see a lot of HPV 30 and 32 coming up, which are rarer strains from which you don't have a lot of protection. So even with the vaccination. So basically, the screening program and vaccinations have to go hand in hand if we have to battle this particular disease. Overall, there are different kinds of tests available in the market. So starting with LBC. So LBC is the lipid-based cytology. That is the test that we are kind of focusing on in combination with the artificial intelligence that we have built up. And so it combines the basics of LBC technique with digitization through microscopy and then adding a layer of AI on top of it so that it becomes much more easier for the pathologist to view and look at the cell samples and provide uh, overall results, right? Like what are the different kinds of precancerous cells or the different kinds of cells that he is observing on the microscope. So rather than using a microscope, he's able to view some of these things on the screen and diagnose the issues much early. Overall, again, like we are providing or we have created an end-to-end service. So, right. So even somebody who is asymptomatic, they might be able to come in and take this test. So that is an important part that both symptomatic and asymptomatic people can take or have to take this test, uh, considering the virus has a very long gestation period. So it can usually be like 7 to 10 years before the actual symptoms show up, even though the person is infected with HPV. A lot of times, what happens is that even though the person is infected, it might not show up as part of, like, it's not showing up as a in terms of symptoms, right? So that might happen, the symptoms, and some of the times the body can also fight the virus and take care of it after 3 to 5 years. So precancerous cells doesn't exactly mean that cancer is going to form. So precancerous cells generally identify that, okay, HPV is there, so we generally go for a sequential testing thereafter and ensure that what is the kind of virus or what is the type of viral strain which is there in the system. So end of day, we are looking at providing a end-to-end service. Now, overall, from our standpoint, what we have been able to do again is value engineer the collection kit, which was a significant part of the current expenditure. We have been able to reduce the cost significantly by 60 to 70%. We have automated the entire slide processing mechanism. So the staining, getting the sample on the slide, the centrifugation process, and finally, the heart of the technology is the diagnostics and the reporting process. So the diagnostics basically is a digitizer, as I said, combined with the artificial intelligence that we are able to provide very significantly accurate results. So internal studies indicate sensitivity rates of around 99.6%, which is almost at par with an HPV DNA testing, which is a very much higher uh, sensitivity project. So thanks, Mr. Soni, for raising the hand. We'll come back to it maybe in a couple of minutes once we are in a good place. So yeah, this is how it works. It's so we take a scan of the slide, put it under the so it's a digital microscope, captures the image 50,000 odd cells, and it points out abnormalities across the smear. So a live example is how you see it now. So say this is a cancerous cell that you're seeing across the 50,000 odd cells. And what the AI will do is mark out each of these areas of abnormality and label it across the slide. We are able to check and figure out if it's ASCUS, ACH, LSIL, HSIL. So this is according to the Bethesda system. So we are able to do that pretty comprehensively. And our AI model has been trained with over 2,000 odd samples, different kinds of cell types and abnormalities, and this kind of helps us understand what is the, like, if there are any abnormalities coming up on the slide. The UI and tech kind of looks like this. So the pathologist is basically looking at a grid view of the different abnormal cells that are across the smear. So when we are looking at this one dot, this is actually almost a 3 GB picture with 50,000 odd cells, as you saw here. So this is the dot that gets created after. So this is at 40x zoom, and you're looking at basically microscopic cells, right, on this particular image. And we run the AI, and finally, this is how it looks like. You're able to see different types of these abnormalities prop up in a grid view at the pathologist end, and he's able to provide a subjective assessment and provide the diagnosis. So overall, the technology is able to give almost, so we are looking at almost zero false negatives. And in terms of case discussions, I think one of the cases which came up during our process is that there was uh, one particular slide which had, so we had detected LSIL, but then overall, when we looked at it through the AI, there were uh, significantly higher complications. So there was basically squamous cell carcinoma that was not detected by the pathologist, but then the AI was able to detect it. So that was like one of the really interesting cases that there are, from a human standpoint, even if we are some of the times we miss out on a lot of these cases, but at from an AI is not really missing any of these cases which come across. So that has been like a very big success story for us as we have developed this technology and put this into practice. One of the other success stories is that we partnered with a lot of the non-profit organizations across India, and we are looking at rural Telangana as a test bed. So a lot of these, uh, one of these non-profits, they had been doing the cancer screening projects for like almost 5-10,000 people, but they never really came across a positive case. Whereas we know that there has been significant incident rates across rural and urban populations, but this never came across. But then when we partnered with them, we said that, okay, we'll do, say, 100 tests for free, and you just get over and collect these samples. So during that test, first camp only, out of 86, we found almost 6 to 7 people with uh, abnormalities, one person in advanced stages of cancer. So that is how much this problem is actually. And we are seeing significantly very, very high incident rates across populations in rural areas, either due to hygiene problems or this being a sexually transmitted disease. So overall, the problem, even though, say, the NSSO sample surveys, they kind of look at it as like they provide statistics in the range of 1 to 1.5% incident rates, but actual reality on the ground is much more complex. It's much more severe. So it's kind of it sends shivers down our spines at most in a lot of cases, to be honest. So that has been the case for us as well. Moving further, like we are also trying to capture a lot of these abnormalities which are much more rarer. So glandular malignancies and atrophic LBC smears are some of the data. So it's just that the data is unavailable, or it's much more rarer to train the model. But we are trying to get more of these samples trained. But even without the rarer cases, the level of robustness that our AI has and the overall service structure and the service model has, it's been like extremely good. So just in terms of rural camps, we have done over 1,000 samples. We haven't missed like a single case. With collaboration with CPAT Lab, which is our clinical partner, we have done over 5,000 odd tests till date, and we are very, very proud to say that not a single case has been missed till now. We have Dr. Ranjani actually on the call as well to answer any questions regarding this. Uh, Overall, again, we are also on the other side. in terms of the digitization process, we are collaborating with IIT Hyderabad to build up a low-cost digitizer, which we feel that would be accessible across India. We should be able to deploy and launch this as a much more compact product and service in different places once we kind of pass on basic prototyping, as well as like we do have it as a prototype, but then we do think that it has much like it has to go another few steps to get to a place where we can scale it up, to be honest, and we can integrate our AI with the device itself so that we can have a point of care uh, process for detecting cervical cancer. So we are not we right now we are operating with a center of excellence model where the sample or the kit collection kit has been distributed to the NGO partner. They kind of collect it and send it over to the lab for processing. So that has been the model right now, but we do think that in a couple of years or 3 years, we should be able to make this into a point of care uh, device, which can be used for providing results directly on site. So that is what the goal is in terms of the product development. Uh, on the other side, we are also looking to get the FDA or the Indian CDSCO licenses for our devices and the software. That is also again in the process. But then right now, the way that we are positioning the service is more of the AI being used as an assistance to the pathologist. So it's a human plus AI application that we are kind of trying to build up, and it's been very interesting overall. So I know it's we are almost 20 minutes into the call. There have been questions and comments that I can see, and we have Kimo and Ranjani on the call as well to answer any questions regarding the technology. So yeah, open to questions. Feel free to raise your hands and unmute and ask the questions.
So there is one question already from Amrish.
Yeah.
Probably this is for Ranjani.
Yeah. Ranjani, so the question is that have you done a cancer stage-wise analysis? What is the cancer stage-wise F1 scores?
Yeah, good afternoon. Actually, we've been principally looking at pre-cancer. Even the one case that we did detect in the camp was Hetzel. It's still pre-cancer. So we haven't, so far, in the course of these camps, we have not detected actual cancer.
Hope that answers the question. Yeah, overall, the AI right now is only identifying precancerous cells.
It does detect cancer as well. I mean, obviously the AI tool detects all grades of precancerous and cancerous cells. However, in our camps, we have not detected a frank squamous cell carcinoma. We have only been detecting precancerous lesions. We haven't come across case. Yeah.
So just to make one comment here, the whole screening process is to identify precancerous things so that the prevention can be taken.
Thanks, Kimo. Shreyans, you had a question? Feel free to unmute and ask.
Yeah, hello. Can you hear me?
Yeah, we can hear you.
I was just asking, is it just for this LBC or is it for other slides of histopath as well?
AI tool we have developed is for cervical cancer screening. So LBC pap smears only.
Because there are a lot of other organs now that has cancer as well. So does the AI work for them or them also?
No. Our focus currently is on cervical cancer screening. So the tool we have developed is to be applied on LBC pap smears after digitization. So the pap smear is made, the slide is digitized, and then the AI algorithm is applied.
So the algorithm can be basically you have fed the type or the shape of the cell that to AI, right? So you can
Yes.
feed the same thing for thyroid, you can feed the same thing for breast, so it can detect through AI, right? But you haven't made it yet. It's like
Yes,
that.
not yet, not yet. Of course, in the future we do have plans. Next, we actually want to work on breast cancer. Our focus is on screening and prevention of cancer at the moment, rather than diagnostic. Obviously, in the future, since we have the capability, we will develop tools for other cancer diagnosis as well.
So don't you think like this kind of AI would like make pathologists and radiologists a little bit let down or something like that?
To just put it in perspective, Shreyans, radiologists, pathologists, they're all relatively rare and definitely a precious breed, right? Medically qualified, subspecialized. So this definitely cervical screening is a very low level activity. We have 50,000 cells in a pap smear and you have to pick up 5 to 8 cells. So it's a waste of time, for a pathologist to spend 10 minutes just to pick out this 5 or 7 cells, which AI does very easily. So, and then also the reason why, for instance, in India, why hasn't the government got into, a mass scale cervical cancer screening? Because it doesn't have the resources to screen that many slides. Imagine, about the population of 150 crores, maybe 50 crore women in the screening age group, right? There are not enough doctors anywhere in the world to look at those slides. So definitely, most of the things that currently AI is doing is to help doctors. It's going to be a very long time before it can replace any doctor. Not maybe in the next 1 to 2 decades at
Like
least.
right now we have for radiology we have a system called PACS. Okay,
Yes,
so
yes,
that system is utilized by all the colleagues from other branches as well. So
yes,
even if
yes.
you don't report it, same for pathology as well. Even if you don't report
Mhm.
it,
Yeah,
they see the scan by themselves and then they argue with you, no, no, I have seen this, and then you have to tell them no, it's like that. So if
yeah.
you cannot basically argue with AI, right? Because the
Correct, correct.
information is being feed, and you cannot argue that AI is wrong. Like most of the
Correct,
time,
correct. No, that is true.
99% of the time AI won't be wrong, right?
Correct,
Until
correct.
and unless the information being fed is wrong.
Yes, yes. No, I agree with you on that, Shreyan. But at the moment, pathology, it hasn't caught up. I mean, radiology is much ahead. Pathology is very much behind in all this. And also, it's very complex, isn't it? No two tumors or no two slides look alike. So it's a
That
very
is the
long way for AI to be really significantly applied in pathology. Cervical smears, like I said, is a very basic thing. It's like looking at a blood smear, right? So, pathologist time is better utilized. Just like maybe a radiologist time is better utilized doing more maybe intervention stuff or more high-end quality work. Maybe the routine stuff AI can look at, but still there is room for qualified people.
So I think Ambarish had another question. Has any of the precancerous positive detection progressed to cancer or even stage 0?
We've only been doing this for like, it's been 6 to 8 months since we went live. So the 2 or 3 high-grade cases that we had were treated. So that is also the thing, right? Once you've detected a high-grade lesion in a cervical screening program, it's absolutely our duty and responsibility to make sure that the lady is treated before she develops cancer. So that is when the loop is closed. So definitely on our watch, we will not let women develop cervical cancer newly after we have screened them.
Thanks, Ranjani. Satish, you had a question?
Ranjani madam, I think what's the edge over on HPV DNA test compared to our pap smear with LBC? Any
Yes.
USP you have?
In the sense of, obviously HPV is straight away a molecular test. We do that in our lab as well. And it's expensive, right? It's not yet at the stage where you can apply it to 50 crore women. You need a PCR machine and you need the qualified personnel. The cost of the test, just the baseline cost of a good HPV test is about 700 to 800 rupees. Right? If you add overhead costs, it's upwards of 1,000 rupees. So at the moment in a country like India, it's very difficult to do a mass HPV screen. But saying that, overall, in my mind, I mean, I'm a pathologist with close to 2.5 decades of experience. A significant proportion of this abroad. So this is something that I constantly think about. See, HPV is the causative, virus, right? In the age group of 20 to 30, universally, 100% of women are going to get exposed to HPV. Out of this, only 10% develop pre-cancer. And out of that 10%, 2 to 3% develop cancer. So even if you did detect a positive HPV, still in other countries, they go back and do a pap smear after HPV, right? So either you triage first with LBC. When we say triage, the first line of testing is by LBC or by HPV. Either way, even in the Western world, they follow this. Either do HPV or LBC. So if HPV is positive, they still have to go back and do cytology. Now 20-30% of women will turn out to be HPV positive. Then again, you have to go back and do LBC. So in the screening program, see if it's small numbers in a metropolitan city, within a hospital setting, all that is very easily done. Supposing you're going to a remote place, you have screened 1,000 women to go and 20-30% turn out HPV positive. Then you have to go back and get a cervical cytology sample for them. So that issue is there. And this is the thing. See, HPV as a primary test does have its drawbacks because, like I said, out of 100 women infected by HPV and who show a positive test, only 2 or 3 are going to actually develop cancer. So why do a more expensive test when you have a less expensive test?
Regarding the accreditation part of that, your HPV AI tool, has got any accreditation?
Yes, we are working on it. We're working on a large validation study. We're looking to get it to run it across 60 or 70,000 samples. We have archival material, plus we are conducting camps. Maybe in 2 or 3 months, the validation will be done. And then we are going to publish as well. That is the academic side of it. On the other side, we have applied for licenses at all levels, nationally and internationally. So both are happening simultaneously.
So when will we be expecting that to be happening?
Actually, at the moment, we are using it in our lab. We do about 1,500 samples a month routinely. So this is just as an adjunct to the pathologist. So at that level, it is already available. It's not reporting out. We are hoping by the time the validation is done, then the AI can independently report out negative cases and only positive cases have to be looked at by pathologists. Maybe by early 2025, we are hoping to achieve that.
Thank you very much. We'll get in touch with you. Thanks a lot.
Yeah, thank you.
Thanks, Satish. So, any other questions from folks on the call? Yeah, Shreyans, go ahead.
Can you hear me?
Yeah.
My question is that the AI tool that you are using, can you share it with us, or you're going to get it patent and then we'll finding it on Play Store?
So right now we are using it internally. To be honest, the AI tool is not really we are providing this end-to-end service and currently part of the lab. I think once we have the licenses in place, we can take it commercially out. But nothing right now, to be honest.
So, whose help did you take to make it, or some engineer?
It's completely built by us. So, Chemo and me, and we have some of the other folks on the call as well. So it's been done completely internally with the help of Ranjani as the clinical advisor.
And IIT Hyderabad helping us with the hardware.
Yeah. Let me make the main thing. Now, you would need engineers, right? How would a doctor make this AI tool?
No. So we have engineers in the group.
This is me.
Comment. This company has been founded and managed by people with more than 25-30 years of experience in all disciplines, especially in areas of imaging and software. So X-ray, electronics, software, AI, these are all strengths that the core team has developed.
It takes a lot of people to make this kind of thing.
Yeah. Mr. Krishna Mohan, in fact, he's the principal brains behind the AI itself. He has, again, 3 decades of experience and multiple patents from top German universities in AI imaging. So, obviously, a doctor is only only to provide maybe the clinical input. It needs a hardcore engineering team like you just mentioned.
Okay.
So I think if there are no other questions, and we are almost at the top of the hour, thanks everyone for joining in. It was lovely talking to all of you, and thanks Ranjani, Kimo, Madhu for joining in as well, for answering some of these questions and keeping everyone engaged. Feel free to reach out to me, or like feel free to reach out to me on mail or uh, phone or anything, in case this is of interest, or this is something that you want to be associated with. We are offering these services more from a B2B perspective right now. So at least we are collecting and providing the kits to the gynecologists as well as pathologists, and getting these reports out from our lab. So feel free to reach out to us for any opportunity or anything that you might. Any other questions? I'll just keep it for another 30 odd seconds, and I think then we can close out. So feel free to raise your hands. So yeah, okay. I think we are almost at the top of the hour. So thanks everyone for joining in. Really appreciate all the inputs, all the questions, and keep tuned. We'll keep on keeping you sending information on the camps that we are doing, and whatever we are publicizing as well. So thanks everyone for joining in. Lovely talking to all of you. Bye.